I'm Dr. Annixter, and I'm now going to be covering the advanced endocrine and metabolic systems. Basically, we're going to talk about both physiology and, more importantly, the pathophysiology of endocrine hormones and relate it directly to anesthetic management. We're going to be covering the pituitary, thyroid, parathyroid, the adrenals. And we're going to talk a little bit about, we're going to mention carcinoid syndrome and talk about the pancreas as well. So let's begin with Cushing's syndrome, which basically just refers to hypercortisolism in general. Cushing disease specifically refers to hypercortisolism when it is caused by a pituitary tumor. So anything else is Cushing's syndrome, just to be picky. So you can have also hypercortisolism from an adrenal tumor. You can have it from ectopic secretion of ACTH. Obviously, you can have hypercortisolism iatrogenically as well. So you're going to have maldistribution of adipose, hypertension, hyperglycemia. Because of the catabolic effects of the hormone, you're going to have protein breakdown, skin, muscle, collagen. Effects on bone. Again, your the protein catabolism affects the muscle. Also, immunosuppression. The vision changes are primarily if there's a pituitary tumor, you can have pressure on the optic nerve and mental changes. So, opposite of Cushing's syndrome would be Addison's. So instead of too much cortisol, it's too little or no cortisol. So primary would be no adrenal cortex, and therefore no cortisol. You'd be lacking the aldosterone as well. Different causes of destruction of adrenal cortex. Secondary Addison's, no pituitary, so therefore no ACTH, and therefore no cortisone. There may be an effect on the other pituitary hormones as well. And then finally, if the hypothalamic pituitary adrenal axis has been disrupted, you can have a failure of appropriate release of cortisol. I think that's a little pushing it, but if you want to be really paranoid. So with chronic Addison's disease, so chronic low cortisol, fatigue, weight loss, anorexia, hypoglycemia. In primary Addison's, where you have an intact pituitary, you'll have very high levels of of ACTH, which is released with melanocortin, which can cause hyperpigmentation, especially at areas of trauma or old scars. And also because of the lack of aldosterone, since again that's a hormone from the adrenal cortex, you'll have hyperkalemia and hypovolemia as well. In secondary Addison's disease, you won't see these other two findings. So acutely, so basically you have Addison's disease and you encounter some kind of stressor, whether it's infection or tissue trauma. You'll have hypotension, and in particular, catecholamine unresponsive. You can have severe abdominal pain. It might even mimic a surgical abdomen, and of course, death. What is it about not having cortisol that makes you die in the setting of stress? It's not specifically clear. So stress dose steroids are designed to prevent an Addisonian crisis. If you are treating acute Addison's disease, with the hypertension and cardiovascular collapse and whatnot, you may need more hydrocortisone. So more about 2-aldosterone. Classically, hyperchloremic metabolic acidosis with the hyperkalemia. In some situations, you can have hyporeninemic hypoaldosteronism, which can be seen in mild renal failure and chronic diabetes, which will look like this. On the flip side, too much aldosterone, so basically an aldosterone-producing tumor. So obviously hypokalemia, because the aldosterone is still being produced even in the setting of reduced potassium. The key thing is although aldosterone is causes the retention of sodium, these patients will usually not have edema, and it's not quite clear why they wouldn't. It's attributed to the production of atrial natriuretic factor, which would prevent these patients from having edema and volume overload. So growth hormone, too much growth hormone, not a good thing. So until the epiphyses of the long bones have fused, you will have gigantism and increased linear bone growth. And with that increased linear bone growth and that growth, that magnified growth spurt, you have the risk of kyphosis or scoliosis. Then after the growth plates have fused, you'll have just bony growth, which can prognathism, frontal bossing, enlargement of the joints. Because of the soft tissue growth and soft tissue overgrowth, for the joints, but also organs. In particular, that we would be worried about as anesthesiologists, the tongue and pharyngeal tissues will have growth that can lead to obstructive sleep apnea, as well as bony overgrowth and soft tissue growth in the neck can cause recurrent laryngeal nerve stretching, hoarseness, or even vocal cord paresis, as well as carpal tunnel syndrome, again, overgrowth of the tissues in the carpal tunnel. In particular, a diastolic failure of the heart. So things to worry about: big patients, the prognathism can cause difficult mask ventilation, as well as any malocclusion, and also the increased soft tissues in the oropharynx. Get to worry about, again, soft tissue growth, bony tissue growth, and you may need a smaller endotracheal tube than you expect. So here's a picture just to kind of put all of those weird things together. You see the prognathism, frontal bossing, incipient carpal tunnel syndrome. You have the anesthesiologist looking at the patient and wondering how exactly they're going to find an endotracheal tube that's going to fit into this patient. Even if the patient may have a smaller glottis just because of overgrowth, you're going to need a longer tube. All the distances are going to be larger. Everything is going to need to be bigger. A normal face mask may not fit this patient. So again, arthropathies, neuropathies, positioning is going to be a big issue for these patients, not just because of their size. Regional anesthesia is going to be an issue. The hypertension, diastolic dysfunction will be an issue. The insulin resistance will be an issue. And again, concerns about obstructive sleep apnea and airway management. Moving on to the pituitary, you have antidiuretic hormone, and again, that's released in response to increased blood osmolality. Primarily, it also is not quite as sensitive, but it is also released in response to decreased blood volume. So basically, the renal filtrate, the free water in the renal filtrate is permitted to travel to the hypertonic renal interstitium once the renal collecting tubules have been made permeable. That is what creates the hyperosmolar urine. So if you're releasing antidiuretic hormone inappropriately, so it's SIADH, reasons for that might be lung trauma, lung infection, lung tumor, CNS tumor, CNS trauma, CNS infection. Basically, this would cause the retention of free water. The kidney is not able to secrete free water. It's all going into the hypertonic renal interstitium from the ultrafiltrate. So the urine will be very concentrated and the blood will be less so. So fluid restriction, plus minus loop diuretics, that's going to impair the kidney's ability to create a concentrated urine. If the patient is symptomatic, so altered mental status or seizures, you may need to correct the serum sodium, serum osmolality more quickly. Don't correct it too quickly. So this is the opposite. This is too little ADH. So if the serum sodium goes down, if there's a problem with retaining too much free water, that's syndrome of inappropriate antidiuretic secretion. If the patient is not concentrating their urine, if the serum sodium goes up and the serum osmolality goes up, that's diabetes insipidus. They're peeing their brains out. Don't mix these up. So basically, this could be a failure of production both neurogenically versus nephrogenically. So either the posterior pituitary is not responding by releasing ADH, which is very easy to fix with exogenous hormones. So you can give DDAVP to concentrate the urine, or the kidney may not be responsive to antidiuretic hormone. In some cases, it may be receptive to very, very high doses, so pharmacologic doses of hormone. Basically, in these patients, you need to maintain plasma volume, you need to maintain serum sodium. Consultation with an endocrinologist may be helpful. Moving to the thyroid. So again, thyroid hormone, big picture, maintaining metabolic rate. The amount of thyroid hormone is going to change the ratio of beta adrenergic receptors versus alpha adrenergic receptors. That's a really easy way to sort of remember a lot of the different effects of thyroid hormone excess or lack thereof. Thyroid can be affected by surgery, radiosurgery. There's a couple different drugs that'll affect. So too little thyroid hormone, that means too much alpha versus too little beta. So you're going to be you're going to be bradycardic. You're not going to have a lot of beta stimulus. You're going to have an increased SVR. And so even though the cardiac output is probably decreased, you're still going to be hypertensive. Too little thyroid hormone, so that's going to be a negative inotropic effect on the myocardium, both because of the lack of beta-adrenergic stimulus, as well as the intrinsic effect of the hormone on the myocardium. The collection of glycosaminoglycans causing myxedema. Two anesthetic implications of that would be sort of macroglossia, which might make airway management more difficult, as well as neuropathies such as carpal tunnel, which would make, which might bring the patient to surgery, as well as make positioning more difficult. So other symptoms, again, related to decreased cardiac output, increased systemic vascular resistance, and also decreased metabolism. The mental slowing is pretty profound and very easy to notice clinically. On physical exam, you may also notice diminished deep tendon reflexes, in particular a slow relaxation component of the DTRs. Hypothyroidism may be associated with other endocrine dysfunction, so this might be a red flag to worrying about possible Addison's or other organ dysfunction. So if you have too little thyroid hormone and you encounter a stressor, particularly cold stress, actually, but also infection and trauma, these patients will become hypothermic, comatose, congestive heart failure. The treatment is basically they have too little thyroid hormone, give them extra thyroid hormone. If you are suspecting that they may have autoimmune polyglandular syndrome and that there may be other endocrine systems that are not working properly, you can also give cortisol. So in patients with hypothyroidism, you worry about myxedema causing airway issues, possibly hypoventilation. These patients may have a decreased MAC. Cardiovascular depression, in particular baroreceptor dysfunction in these patients. So now too much thyroid hormone. So this is going to be the opposite. We're going to have a lot more beta and a lot less alpha. So we're going to be tachycardic with a decreased SVR. We're going to have an increased cardiac output, plus minus on the hypertension, depending on how low the systemic vascular resistance is. The increase in cardiac output and cardiac metabolic rate may be poorly tolerated, and so some of these patients may actually go into congestive heart failure from that. They'll be more prone to tachydysrhythmias, which may be malignant. Wide pulse pressure, again, high cardiac output, systemic vascular resistance is very low. Their skin's going to be very nicely perfused, high metabolic rate. So on physical exam, you're going to see an increased deep tendon reflexes, plus minus clonus, tremor. So the exophthalmos is in pure hyperthyroidism would be from the contraction of the muscles that surround the eye, causing the exophthalmos. The lid lag is basically when you ask the patient to look down. The eyelids should lower, and when that doesn't happen, that's lid lag. Weight loss, obviously. Everything causes muscle weakness, apparently. Now, in the case of Graves' disease, in addition to the exophthalmos that you can have from the increased tone of the muscles surrounding the eye, you can also have an infiltrative process that causes exophthalmos as well. And this may or may not follow with the symptoms of hypothyroidism. Also in Graves' disease, you'll have a specific myxedema. Apparently it's itchy as well. You can also have iatrogenic hyperthyroidism, so excessive release of thyroid hormone secondary to administration of iodine. And also certain drugs can cause hyperthyroidism as well. A sort of a subset of sort of the facetious self-administration of thyroid hormone. There's a couple of case studies of patients who were not necessarily taking their thyroid hormone and then decided to take all the missed doses on one day. So I'm not quite sure what group that would go into. So if you have too much thyroid hormone and then you have stress on top of it, so this is increased release of thyroid hormone on top of an already abnormal baseline. These patients will be incredibly hypermetabolic, and that's where the hyperthermia comes from. This is one of those differential diagnoses of, this could be MH or this could be, for example, thyroid storm. Because of the hypermetabolism, they'll be both hyperthermic and hypercarbic, but they shouldn't show any signs of muscle breakdown like you might see in malignant hyperthermia. The other thing is they'll have the tachycardia and tachydysrhythmias, which again can become malignant. Which is not a primary feature of malignant hyperthermia. So again, altered mental status, cardiovascular collapse, so they can go into CHF as well, just for different reasons. So the treatment of thyroid storm, inorganic iodine and cortisone to try and inhibit further release of the thyroid hormone. Propylthiouracil also is going to inhibit release. That's going to take a little bit longer, but propylthiouracil also will inhibit the peripheral conversion of T4 to T3, so to help stop the production of the active form of the thyroid hormone. Symptomatic treatment would be beta blockers, and it's very key. You need mixed beta adrenergic blockers. You don't need your beta 1. You need that beta 2 action. That's very, very important to stop the hypermetabolism and the malignant arrhythmias. And so you're going to titrate that to temperature and heart rate. So bad things that can happen during thyroid surgery, just speaking of the thyroid. Obviously a hematoma at the surgical site, which then becomes, because of the surgical site, is also an airway emergency. The recurrent laryngeal nerves travel right by the surgical site, and paresis of both of those can cause an airway emergency, as well as hypocalcemia, causing laryngeal spasm, causing closure of the vocal cords, causing an airway emergency. So hungry bone syndrome, basically the parathyroid hormone causes release of calcium from bone after it's been present for at very high levels for a prolonged period of time. Then when it's removed, all of a sudden the bones start resorbing serum calcium, and the patient can have can suffer hypocalcemia from that. That's usually not immediately post-op. So hypocalcemia. Trousseau's sign is when you inflate a blood pressure cuff and on the arm, and you would see a spasm in the hand. And Chvostek's sign is the one where you tap over the distribution of the facial nerve, and you see facial twitching. And the primary concern for us in particular would be airway embarrassment from laryngeal spasm. but hypocalcemia can also cause cardiac arrhythmias as well. And the treatment would be IV calcium, and of course, always beware of extravasation of intravenous calcium because it can cause tissue damage. So hypercalcemia, on the other hand, is a lot less exciting than hypocalcemia. Basically, overproduction of parathyroid hormone. So either an isolated adenoma or hyperplasia of all the parathyroid glands. There are some drugs that can cause hypercalcemia as well. In secondary hyperparathyroidism, it's a hyperplasia of the glands secondary to prolonged hypocalcemia. And with the renal dysfunction, you also have the decreased vitamin D as well. That would tend to cause hyperactivity of the parathyroid glands. And in tertiary hyperparathyroidism, basically all the changes from secondary hyperparathyroidism persist. So even though the stimulus has been removed, you still have the hyperparathyroidism. You can also have tumors producing hormones that achieve the same function as parathyroid hormone. And finally, there are some diseases such as granulomatous diseases that can produce ectopic vitamin D, which will also cause hypercalcemia. So signs and symptoms, again, not quite as exciting as hypocalcemia. And this is one of those diseases that can present very insidiously with a lot of sort of poorly characterized symptoms. It's another one of the quote-unquote great mimics. So again, everything causes muscle weakness. How do you treat hypercalcemia? Fluid. So you get them to pee the calcium out, and the bisphosphonates would prevent them from mobilizing any more calcium from the bone, particularly in the case of hypercalcemia associated with hyperparathyroidism. Moving on to the adrenals. So, pheochromocytoma, both sporadic and inherited. So, signs and symptoms are pretty much what you'd expect them to be for a tumor that releases epinephrine and norepinephrine. Headache, hyperhidrosis, hypertension, hyperglycemia. Because of the chronic secretion of these hormones, these patients are usually volume contracted and hemoconcentrated. The prolonged high levels of catecholamines are toxic to the myocardium. In addition to the increased myocardial demand of the tachycardia and hypertension, and the increased risk of both MI and stroke. So cardiovascular and cerebrovascular thrombosis. Medical management is very important to prevent surgical or perioperative morbidity. So first, decrease the SVR. Depending on how much epinephrine is also being secreted by the tumor, you may also need a beta blockade as well. But Beta blockade in the absence of alpha blockade is a very is a setup for cardiovascular embarrassment, because you'd potentially have an increased SVR, and then with the beta blockade you've removed your beta 2 stimulus, which would be your only vasodilatory stimulus on the vasculature. So not only would you worry about tremendously increased systemic vascular resistance and paroxysmal hypertension, but also you might also worry about coronary vasospasm as well. You want any dysfunction the myocardium may be having due to the prolonged effect of the catecholamines, you'd want that to be normalized. And one thing you can actually follow is you can follow the volume expansion as you're progressively decreasing the SVR. So when you bring these patients to the operating room, obviously you want to prevent any reaction to noxious stimulus. Despite the fact that they've been given both alpha and or beta blockers preoperatively, you can still expect, you still need to be prepared for a release of overabundant release of catecholamines and reactions to any noxious stimulus. So that's either by us or by the surgeon. When the tumor is manipulated, it may also release catecholamines. And then finally, when the pheochromocytoma is removed, this chronic, prolonged secretion of catecholamines is abruptly removed. And this is usually in a patient where the adrenal receptors have been downregulated just because of the chronic exposure to high levels of catecholamines. And in addition to that, we've also given these patients both alpha and or beta blockade. And finally, they may need further volume expansion on top of what's already occurred preoperatively. So how do we do this? Obviously, we use drugs. We need to initially counteract the excessive amounts of catecholamines that are being secreted, both at possibly baseline and also in response to things that may happen intraoperatively. And then, of course, we're going to need to replace some of these catecholamines after the tumor is removed. We're going to need our invasive monitor so that we can do this in a evidence-based fashion. We're expecting wild, rapid swings of blood pressure and heart rate. Carcinoid syndrome. This looks a little bit like a pheo, so with tachycardia and hypertension, and in response to noxious stimulation and or with manipulation of the tumor. And again, this is another one of the things that you can worry about when you have a patient who's hypertensive and tachycardic. So carcinoid crisis, again, you're trying to avoid the further release of all of these vasoactive mediators from the tumor. Serotonin syndrome can also include fever. Okay, so last endocrine system. So you have your type 1 or so-called juvenile diabetes, no insulin. These patients can go into diabetic ketoacidosis. Type 2 diabetes is mostly characterized by insulin resistance, so-called non-insulin dependent diabetes, but these patients may need insulin to control their blood sugar. They are just in general not dependent on insulin to live. Rarely these patients can go into diabetic ketoacidosis. Extremely rarely. So basically, too much glucose causes an osmotic diuresis. It spills into the urine and brings fluid with it. Hyperglycemia affects wound healing. It affects the immune system. Other things that you can worry about with any kind of diabetic that might be on a hypoglycemic, such as insulin, would be hypoglycemia, obviously. And depending on how much hypoglycemia this patient has had, the normal counter-regulatory response may not occur appropriately. So chronic hyperglycemia, and again, this is both type 1 and type 2 patients. It's the same problem. So the hyperglycemia causing the abnormal collagen cross-linking. The prayer sign is basically you ask them to put their palms together and their fingers are unable to fully extend. So microvascular complications, as well as macrovascular complications. As well as neuropathy, which can be both autonomic and sensory. So diabetic ketoacidosis is a really big deal. Again, is much more likely to happen in a type 1 diabetic whose pancreas makes no insulin at all versus a type 2 diabetic where the pancreas classically makes too much insulin. So this is why insulin is part of the hormonal stress response. Because if you don't have insulin, there's no brake on the release of the counter-regulatory hormones. So you have these huge levels of the catecholamines, the glucagon, the cortisol, the growth hormone. The issue isn't so much the release of glucose and the hyperglycemia. That's why they don't call it diabetic hyperglycemia. It's everything else. It's the ketosis causing the profound anti-gap acidosis. That's a really big deal. The dehydration. With kids in DKA, this is the main cause of morbidity. It's not quite clear whether the bicarbonate is a marker of kids with more severe diabetic ketoacidosis or if it's a direct cause of the cerebral edema in these children. So the electrolyte disturbances can be very profound just because of the osmotic diuresis and the acidosis. But again, it's not just this. It's not just the glucose, and it isn't even just the ketosis, but also because of all the counter-regulatory hormones that are being released, the epinephrine, the glucagon, the cortisol. You'll also have hypercoagulability as well and hyperviscosity. You have the hyperlipidemia and the dehydration and the hypercoagulability. So not only in kids, but in particular in adults, the morbidity is going to be vascular and thrombotic. I think DKA would have a lot more cachet to it if it was called like diabetic storm. So in treating DKA, these patients are going to be incredibly dehydrated. So you have to work on that end of the electrolyte derangements, and you have to stop the process. You have to stop the ketosis, and you need insulin. There's been this huge release of channel-regulatory hormones, and you have to start correcting that. And you're not. The only reason you're looking at the glucose is you do not want to make these patients hypoglycemic. So we're titrating our dose of insulin, looking at the acidosis and the ketosis. You're not titrating it to the glucose. And obviously, if there's an underlying cause, trauma or infection, you have to treat that as well. And again, in DKA, usually the glucose won't be horrendously elevated because these patients are trying to pee. The glucose is spilling into the urine as well as all the ketones. If the patient is trying to rehydrate using a glucose-containing fluid, the glucose might end up being high. Or if they're so dehydrated that they're not peeing out all the glucose, they might end up with a high glucose, but typically diabetic ketoacidosis may not be associated with profound hyperglycemia. However, hyperosmolar non-ketotic coma is. So we're lumping it in here because it's something that can happen to diabetics and something that's also associated with hyperglycemia. But in this case, this is classically, this is the elderly patient with the diabetes that has a stress, such as an infective stress, which would promote hyperglycemia, which would cause an osmotic diuresis. However, this patient, for whatever reason, isn't able to volume resuscitate themselves. They're not able to access fluids. They don't have, their thirst mechanism may not be working properly, or they may have renal impairment. So they're not they're not replacing that osmotic diuresis. They're getting severe hyperglycemia, severe hyperosmolality, but they are non-ketotic. So let's talk about type 2 diabetes for a little bit. Initially, it's going to be characterized by insulin resistance, which is compensated for a time by release of more insulin from the pancreas. So you'll have hyperinsulinemia, and then at some point the pancreas is unable to compensate by releasing more insulin, and these patients will start showing elevated glucose. The symptoms that usually bring them to finally to diagnosis would be the polyuria, polyphagia, polydipsia, and pruritus. And pruritus is, so I can remember that they tend to get urinary tract infections and yeast infections more often. And so usually the diagnosis for these patients is delayed because they're not presenting, as the 5-year-old with the sweet urine, or the teenager with DKA. They've been having prolonged high glucose, and if you're not monitoring it, you won't see it until they have these sort of flagrant symptoms. So going along with the insulin resistance, and not every type 2 diabetic looks like this, but a lot of them do. So all going together, plus minus the smoking. And again, the hyperglycemia is going to cause both macrovascular and microvascular complications. The hypertension and smoking or smoking are going to potentiate these. So these patients are at risk of heart attack, stroke, decreased renal function. With the microvascular complications causing local decreased blood supply, the neuropathy causing decreased sensation and abnormal foot positioning, and the macrovascular complications causing decreased blood flow to the foot. The common intersection of those problems lead to diabetic ulcers, and that's ulcers in the feet, which, because of the immunosuppression of the hyperglycemia, tend to get infected. So medications, you can try to increase the release of endogenous insulin. You can try to decrease the gluconeogenesis. Because of the insulin resistance, these patients not only after a meal will be hyperglycemic, but even while fasting will be hyperglycemic because of the increased rate of gluconeogenesis, the inappropriate increased rate of gluconeogenesis. And so some of the drugs will affect that as well. So I can't emphasize this enough. If you've got a patient who's on metformin, if you want to decrease, if you want to, hold the metformin prior to, say, a diload that they might get for a radiologic procedure, that's fine, but it's really important to hold the doses after the diload as well, because the concern is this drug is renally cleared, and any decrease in renal function may lead to drug accumulation, which would put the patient at risk for lactic acidosis. So what do we look at with these patients? Because of the association with obesity, with type 2 diabetes, that's one part of your airway exam, and also chronic hyperglycemia can cause stiff joint syndrome. Microvascular complications can lead to renal dysfunction, which may or may not be represented in as well as hyperenemic hypoaldosteronism. Neuropathy, both because we would be worried about positioning issues, but also you'd worry about decreased gastric emptying and potential effects on the cardiovascular system as well. So macrovascular complications, both cardiovascular disease and cerebrovascular disease. What do we do with their pre-op medications? Obviously, we're asking them not to eat preoperatively, so any medications that are going to take into account, say, breakfast, should not be given. And after the procedure as well, these patients may be NPO for a prolonged period of time. So the insulin that they take to take care of their blood sugar after breakfast, they should not be taking. For patients with type 1 diabetes, it's really, really important that they have some amount of insulin while at the same time trying to prevent any hypoglycemia. If they don't have any insulin, if they haven't taken any insulin at all, you could worry about the potential for diabetic ketoacidosis, especially depending on the surgical stress that you're going to submit them to. The patient's endocrinologist may be helpful both in preoperative recommendations in terms of how much insulin they should be taking, say, in the morning or in the evening before surgery, and also how they should manage their insulin postoperatively, especially if their NPO is going to be prolonged. So again, it would really, we don't want hyperglycemia, but hypoglycemia is also bad. Fortunately, depending on the surgery, you'll have the surgical stress response will tend to cause hyperglycemia versus hypoglycemia. But undetected hypoglycemia is a very, very bad thing. And the patient cannot tell you when they are under general anesthesia. Hyperglycemia, things to worry about, obviously osmotic diuresis, wound healing issues. So prevention of hyperglycemia is very important. Prevention of hypoglycemia is very important. As far as how you're going to give insulin in these patients, in operations with large fluid shifts, you may not have good subcutaneous perfusion, so you may wish to give the insulin via another route. Particularly if you want tight control of intraoperative glucose. And finally, pancreatic transplants, goals, very similar. So both hyperglycemia is toxic to the new pancreas. So tight control of blood glucose is important. When the graft is reperfused, hypoglycemia is very important, so it's very important to keep an eye on that. And then finally, optimize perfusion of the graft. And since these patients are usually diabetic, with all the comorbidities that tend to go with diabetic patients, you have to account for any cardiac or renal disease as well during the transplant.